Good afternoon, everyone. Thank you to the organisers for the opportunity to share this data. It's data from a proof of concept study of an oral new HIV-1 Capsid inhibitor, VH4004280, which I'll refer to as 280 as we move forward. Here are my disclosures. We all know that advancing long-acting antiretroviral therapies is really key to provide people living with HIV and people who would benefit from PrEP more choice, as we've heard earlier. We also know that long-acting treatment and prevention has the potential to enhance people's quality of life and to improve adherence. And all of this, we hope, will help pave the way to ending the HIV epidemic. VH280 and also VH499, with some data that we presented earlier at CROI this year, are two new investigative HIV-1 Capsid inhibitors. Both are highly potent with picomolar potency and have broad antiviral activity. Based on databases such as Los Alamos, we know that for both 280 and 499, the prevalence of de novo resistance should be very rare. At IS in Munich last year, we presented data from two first-time in human studies of orally administered 280 and 499 in people without HIV. And in that, we showed across a range of single and multiple doses that both 280 and 499 were well tolerated. We showed that they had a long oral half-life between 6 and 9 and 2 and 3 days for 280 and 499 respectively. And I think importantly, thinking to the future in terms of treating an aging population with comorbidities and polypharmacies, neither 280 nor 499 inhibit or induce CYP3A4, and so we think have a low liability to cause drug-drug interactions. As I mentioned before, at CROI earlier this year, we presented the data from the Cinnamon study, which included both 280 and 499 from the proof of concept study, and we showed that 499 was highly potent, was well tolerated, and had a favourable safety profile in people living with HIV. Today we were able to present the same antiviral pharmacokinetic safety and efficacy data for 280 from the Cinnamon study. And based upon this data and the data that I mentioned from the two first-time in human studies has led ViiV to make a decision in terms of which of the two drugs we'll take forward. So this is the Cinnamon study. It's a phase 2A double-blind randomized placebo-controlled study. It included both 280 and 499. Participants had to be aged between 18 and 65, naive to antiretroviral therapy, and to have a baseline HIV viral load of 3,000 copies per mil or greater, and a baseline CD4 count of at least 200 cells per millimeter cubed. Within the 280 component of the study, we recruited 21 participants. 18 received 280 and 3 a matching placebo. Individuals were dosed on day 1 with a single oral dose of either 100, 300 or 600 milligrams, and then were followed over a period of 10 days of monotherapy to day 11, where they commenced oral and combination antiretroviral therapy, and then were followed up for a further 28 days. Primary endpoints were the maximum change from baseline in plasma HIV-1 RNA through to day 11, with secondary endpoints including the safety, tolerability, pharmacokinetics, and exposure-response relationship. This slide and this table summarizes the participant demographics and baseline characteristics per column according to dosing group, and the pool data across all 21 participants is shown on the far right, and broadly this was similar between each of the dosing groups. The median age across the 21 participants was 32. The majority were male, the majority were white. The median baseline CD4 count was 340, and the median baseline viral load was 4.8 log to the 10. You can see here the primary endpoint. So overall, 280 demonstrated potent antiviral activity. In the graph, you can see the mean change from baseline in plasma HIV-1 RNA over time for each of the dosing groups. And then in the table below, you can see the primary endpoint, which is the mean maximum change in plasma HIV-1 RNA through to day 11. Across the 3 active arms, we saw a 1.1, a 1.4, and a 2 log viral load decline over that 10 days of monotherapy in the 100, 300, and 600 milligram dosing groups, respectively. This data is further shown on this graph, which again on the y-axis shows the maximum reduction in HIV-1 RNA over the 11 days per dosing group. In the table below, you can see the geometric mean concentration on day 11 of 280 across the 3 active arms. And you can see going from left to right, from 100 to 600 milligrams, that we see less than a dose proportional increase. And whilst we saw more variable PK following oral dosing than we were anticipating, there was a clear, strong correlation with higher exposures, resulting in higher viral load declines. We saw no participants out of the 18 receiving active 280 who developed phenotypic changes over the 10 days of monotherapy. However, 2 individuals who were receiving the 600 milligram dose were noted to have discordant genotypic profiles for capsid inhibitor RAMs in different assays. Additional and further investigation is needed in terms of in vitro testing to further clarify these findings. Overall, 280 was well tolerated and had a favourable safety profile. The proportion of participants reporting 1 or more adverse events is summarised in this table by dosing group, and then the 18 individuals that received 280 is summarised in the grey column, of whom 7 of the 18, 39%, experienced 1 or more adverse events. These were grade 1 and grade 2 only. There were no trends observed in the types of adverse events, and each adverse event and each drug-related adverse event was reported only once. No adverse events led to withdrawal. There were no serious adverse events and no deaths were reported. There were no clinically relevant changes in laboratory parameters, ECGs, or vital signs. So in conclusion, 280 is a new HIV-1 capsid inhibitor. We've demonstrated that it also has highly potent antiviral activity after a single oral dose in people living with HIV, with up to a mean maximum viral load decline of 2 log. Whilst we saw no emergent phenotypic resistance across any of the participants receiving 280, there were discordant genotypic results in 2 participants which require further investigation. 280 was well tolerated and had a favourable safety profile. And whilst these data for 280 I think are very encouraging, based upon the data that we've previously reported for 499 and the phase 1 data for both drugs, we've taken the decision to take forward 499 as a long-acting injectable drug for further clinical development. We have a number of long-acting formulations for 499, which are being evaluated in phase 1 studies for systemic parenteral administration. I'd like to finally thank all of the participants, the study sites and the investigators, obviously my colleagues at both ViiV and GSK, you for your attention, and I look forward to any questions you may have.